All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to our new show today. The discussion today, I want to discuss two primary topics. One is the Remdesivir not working according to the discovery trial. And the second discussion is about active immunity and passive immunity. I have been getting some comments and questions about the monoclonal antibodies or the antibody cocktails. And the questions are related to that, would that create immunity for us for a long period of time? And I think that it is important that we can understand what is the difference between the antibodies given from outside and the infection or vaccination that occurs and the type of immunities that are produced. What is the difference between them? So for this, let's start. Sobering news on Remdesivir, not really very useful. And actually, given its toxicity, it probably is more harmful than being useful compared to placebo groups. So that is the discussion. Let's start. So here is drbeen.com, and then I'm going to show you the links before we go into the discussions. So this is the link. This is a preprint about the Remdesivir. And here, if you see repurposed antiviral drugs for COVID-19 interim WHO solidarity trial results. So these are still interim results. They might change, but I think that for a greater extent, we can rely on the data and we can look at what the data is saying. This particular result or study is going to talk about Remdesivir, Hydroxychloroquine, lopinavir with the combination with ritonavir and interferon beta 1A. So we'll talk about that in a second. Then I wanted to make sure that all of us are aware of what are the odds ratio, what is the confidence interval, and then what are the p-values and what are various numbers related there. So just a high level. I'm not going to teach statistics. I do not know good statistics, but enough that we can interpret the numbers. Then there is another link over here that is from the Penn State University, and that is also about the confidence interval. And then finally, this is CDC's site. As much as I am not a fan of CDC, there is some good work there as well. So type of immunities. And then finally, this is another link that is the bookshelf on NCBI, which is about the immunity as well. So all of these links are present in the description. So let's start our discussion. So here is the paper. I downloaded that, and now we're looking at the paper. So what this is saying is the following. The basic, let me spill the beans. Remdesivir has no benefit, or at least no statistically significant benefit. And considering the harm or the toxicity it can do, it is actually more harmful than beneficial. So that's the basic summary of it. So now let me just go over what they have seen. So here is how the study design was. And this study was done, conducted by WHO's support. It was done in multiple places in smaller or bigger groups. And then the authors have compiled all that data, pulled that together, and are able to give us some results from it. So see here, from March 22 to October 4, so that is the time frame, 11,330 patients were entered in the hospital, 405 hospitals. And out of those, some patients were not included. And finally, 11,266 patients were included in this trial. 2,750 patients were in the Remdesivir group, 1,411 in lopinavir, ritonavir group, 2,063 in interferon beta 1A, and 954 in hydroxychloroquine, and then 4,088, which were, you can say, control group. Here is what is interesting. So Remdesivir, the risk of death with the Remdesivir. So let me just very quickly go over one more thing before we can read those numbers. So if you see here, for the odds ratio or the risk of death, for example, RR that we are looking at, If that number is 1, that means the intervention group, or the group that is being treated with the drug we are trying to observe, and the control group or placebo group, which is not being given that drug, if the RR is 1, for example, then they both are equal. There is unity in them, there is no difference. However, if the RR is greater than 1, that means placebo group is performing better than the control group. And if RR is lesser than 1, then the intervention group is performing better than the placebo group. So that is the basic idea. However, just that much of the number is not enough. Then what we do is we want to have the confidence interval as well, which tells us that if we take that data and extrapolate that onto the community, then what is our confidence range that 95% of the people would drop in that? What kind of a percentage of people would drop in this risk reduction? So if you see here, the way that we look at that is, for example, here we are saying 95% confidence interval with a range of 0.9 to 1.1. So once again, if the range includes a 1, or we call it unity, that means control group and the intervention group are similar. There is no significant difference between them. On the other hand, if the confidence interval range is lesser than 1, it does not include 1.0, then we have some significant result, which still is not sufficient. We have to add one more number, but at least now it is towards significance. And then the final number that we need to tag on is the power. And the power is very simply for us 0.05. So 0.05 and lesser is a good power. And then 0.05 or more is statistically insignificant. So that is how to look at this data. Now let's look at the numbers back here. So Remdesivir risk reduction, that is the risk of death reduction, is 0.95. So if you look at that, you can say, all right, this is actually reduced risk. So there is 0.05% improvement. However, if you look at the confidence interval here, that is 0.8 to 1.1. So as soon as the confidence interval contains 1.0, that means unity, that actually means both arms are equal. We can say that the intervention arm is trending better, but still they both are equal. There is no significance between them. And then if you look at the p-value further kind of verifies that. Here the p-value is 0.50. So if the p-value had to be showing something significant, then this would have to be lesser than 0.05 of the p-value. So the power of the study of the data and the confidence interval actually show no significance. And we can actually look at the numbers ourselves and look at that as well, that is there any significance or not. So check this out. In Remdesivir group, the number of deaths were 301 out of 2,743 patients. And in the control or placebo group, there were 303 deaths out of 2,708. So the difference between them could actually just have occurred randomly as well. It is not statistically significant. We cannot say that that tiny difference between them is because it is the Remdesivir that has done it. Then top this off with this, that placebo group may not have those toxicities that Remdesivir offered. So from here, the basic conclusion about the risk reduction for death is actually insignificant for Remdesivir. It didn't do anything. Similarly, if you look at hydroxychloroquine, risk reduction is 1.19, or death rate reduction is 1.19. If it was 1, that means the placebo group and the intervention group were equal. Here it is 1.19. That means there were more deaths in hydroxychloroquine group compared to the control group. And then again, is it significant? Is it really correct? Then you look at the confidence interval, which is 0.89 to 1.59. So once again, it contains unity in it, which means it is not significant. Similarly, if you look at p-value, power, that is not lesser than 0.05, so power is also not significant. And again, if you look at the numbers themselves, you can see that as well. So with hydroxychloroquine, there were 104 patients that died out of 947, and then placebo group, 84 patients died out of 906. And again, there seems to be a trend towards more death with hydroxychloroquine, but the significance, statistical significance is not there. This could have occurred randomly as well. Then lopinavir, risk reduction is 1. So exactly 1 means they both are equal. The intervention and the placebo or the control, they were equal. So if they were equal, what is their confidence interval? 0.79 to 1.25. P is 0.97. So once again, this data does not mean anything. And if you look at the numbers as well, you can kind of conclude that. So 148 out of 1,399 deaths, people, 148 deaths versus 146 deaths out of 1,372. So again, this could have just occurred by chance, that one group had more deaths versus the other. There was no statistically significant outcome either towards negative or positive. So not significant. Similarly, the last part, lopinavir. So lopinavir, risk reduction is 1. 0.79 to 1.25 is the confidence interval. P is 0.97. Sorry, I should actually go here. Interferon beta 1a. Risk reduction 1.16. So once again, it is greater than 1. It is trending towards more risk. But the confidence interval, 0.96 to 1.39, is actually containing unity as well. Again, trending towards more damage than benefit, but not significant. Power is 0.11. And you can look at the numbers themselves as well. So 243 out of 2,050 versus 216 out of 2,050. So those extra 27 deaths, for example, if I'm doing the math quickly and correctly, I don't think I'm doing it correctly, but let's say another 27 deaths, that could have occurred randomly as well. And it may have occurred on the placebo side as well. So the data's outcome is not significant. So this is the basic outcome here. I wanted to show you some of the discussion points that were interesting. The main outcomes of mortality, initiation of ventilation, and hospitalization duration were not clearly reduced by any drug. So that's one. The chief aim was to help determine whether any of 4 repurposed antivirals could at least moderately affect in-hospital mortality, and once again, no effect. Then combining data, so they combined all the data for all the various spots where the trials were continuing. Combining data appropriately from all 4 trials, the remdesivir versus control death ratio is 0.91, which is trending downwards, but the confidence interval is 0.79 to 1.05, which includes unity, so not significant. This paragraph was interesting. Interpretation should chiefly reflect not the p-value, 0.21, or point estimate, which is risk reduction of 0.91, but the confidence interval which shows that the range of death ratio is comfortably compatible with the weighted average of the findings from all trials. What they're saying is the overall data is compatible with the individual trials data. Remember, many trials were running and they collected all that data and put that together and then did the analysis on it. And then the confidence interval is comfortably compatible. This absolutely excludes the suggestion that remdesivir can prevent a substantial fraction of all deaths. This is a very important outcome here. One quick question to the audience. Are you able to hear and listen to me? I'm seeing that YouTube audience is probably not engaged. So that there may be an issue with YouTube connectivity, or there may be an issue with the YouTube relay. But the folks who are here, can you please comment if you are able to listen to me? Okay, good. So I think somehow YouTube is not connected, but that's okay. I'll look into that later on. So this absolutely excludes the suggestion that remdesivir can prevent a substantial fraction of all deaths. So that is an important part. Then the confidence interval is comfortably compatible with prevention of a small fraction of all deaths, but is also comfortably compatible with prevention of no deaths, which would be consistent with the apparent lack of any reduction by remdesivir in the initiation of ventilation or the duration of hospitalization in the Solidarity trial. So no benefit. Now, last part. This is about the hydroxychloroquine. I think we've been talking about hydroxychloroquine a lot. I'm going to just show you a couple of tables here as well. If you see here, this is remdesivir. And if you look at this data, the way this data is to be interpreted is the following. This is the active for deaths reported. This is intervention. This is control. So for example, to read this, lesser than 50 years of age, the deaths were 61 out of 961, that is 6.9%. And in the control, in the placebo, the deaths was 6.8%. So you can actually see that they're not statistically significantly different. And here you can see that the risk reduction was 1.08. So that means the risk with remdesivir was a little higher. But the confidence interval it crosses the 1, which is a unity between the two. So that means data cannot be interpreted as good on one side or the other side. And same way you can see for the other as well. What my interest was to look at ventilated versus not ventilated. And why? Because remdesivir is an antiviral. So ideally, the antiviral should be given early on when the patient has not yet reached the ventilation, because the ventilation is a symptom or is an outcome of immune dysregulation and ARDS. So if we are going to give remdesivir or other antivirals, should be given early on. So I wanted to see what happens in non-ventilated. So if you see here, non-ventilated, 203 out of 2,489, so 9.4%. And in the placebo, 10.6%, so almost similar. So even in the earlier stages where the antiviral should have worked, remdesivir did not work very well. And so if you see here, the odds ratio, the risk reduction was 0.86, which looks better. It's trending downwards. But if you look at the confidence interval, that is 0.67 to 1.11. So it crosses the unity. That means insignificant. If I continue on to look at one more table here, that was the various oxygen levels. So once again, my interest is to go to look at where the immune dysregulation has not played in yet, where the virus has still been out there. So if you see here, no oxygen requirement is a phase of the disease where the immune dysregulation is not significant. So if you see there, remdesivir, 11 out of 661, so that is 2% deaths, and control 13 out of 664, that is 2.1% deaths. So once again, no significant difference. So even in the phase of antiviral stage, remdesivir didn't really do much. The risk reductions was 0.9, but the confidence interval is 0.3 to 2.58. So it's kind of a broad confidence interval, means data is inconclusive, that it can be useful. Similarly, if you see in the low and high flow, 198, let me just read the percentages now, the numbers are here, 12% versus 12.2% versus 3.8%. And once again, not statistically significant. Then those who are ventilated. So again, those who are ventilated have the viral damage, but most importantly, they have immune dysregulation. So giving remdesivir at that time may not be very useful. So if you see here, 43% death reduction, and 43% deaths versus placebo group, 37% deaths or 38% deaths. What that means is that remdesivir at that time was not used correctly, but still the data is statistically not significant. So whatever interpretations I'm offering are useless because data is inconclusive. So this is the discussion. The basic outcome, once again, is that remdesivir is not working. So that is the one part of the discussion. Now I'm going to go to the second part, and I am really sorry. I think the YouTube folks have somehow not gotten engaged. The stream did not connect with them. So I will probably upload this to them afterwards. Now, the second part, the difference between active immunity and passive immunity. The reason that I'm discussing this, we've talked about immunity many, many times. The reason that I'm discussing this is the following. I get a lot of comments which are similar to the following. People who are receiving, let's say, Regeneron's antibody, like President Trump, would that provide him immunity for a longer period of time? So that is one question that I see. Another kind of a question is that if I have taken monoclonal antibodies, will I now be protected for 3 years or not? And so I wanted to make sure that we can talk about that. So here is what happens. Active immunity means that our body has become trained to produce antibodies. So how does that work? We have done this discussion before in the past as well. I'm just going to go over this very quickly. What happens is, here is the virus. Virus arrives into our body. Our dendritic cells or macrophages, they pick up the virus, they digest that, they present it on MHC2 complex to naive T cells or CD4 positive T cells, right? We know this. Now, if there is interleukin 12 present, which is usually released by the innate arm, and by the way, innate arm takes about 8 hours to become active against a pathogen. So imagine if I got infected now, it would take about 8 hours for my innate arm to start responding. So imagine the time frame is important. That is a primary difference, one of the primary differences between active and passive immunity. So just calculate the time with me. 8 hours are already spent and the innate arm became active. Now innate arm is trying to activate the adaptive arm. And it would take 7 to 14 days or even more for the adaptive arm to become active. So now in the presence of interleukin 12, a naive T cell, which is also connected to the dendritic cell through the B7 CD28 co-stimulatory receptor, another stimulation is needed. And this is what I call hugs and kisses. So it's not just the hugs that are enough. There have to be kisses as well to kind of verify that there is a bond between them. So then the T helper 1 pathway is engaged. T helper 1, this naive T cell has become T helper 1. It would then release interleukin 2, plus it would also release interferon gamma. So I should have written here interferon gamma. Interferon gamma. Interferon gamma in turn activates the innate arm. So the both of these arms can amplify each other. Then the T helper 1 activates the cytotoxic T cell. Cytotoxic T cell would start killing the cells that are infected. So we know that. But what is important is that now there are going to be some cytotoxic T cells and some CD4 cells and some other T cells that would become memory cells as well. So now this is the concept of active immunity. When this virus is going to arrive into our body once more, then these sleeping cells or these sitting cells that know the virus will be able to react very fast within 8-10 hours or even shorter. And the first time when the virus arrived, this activation can take 7 days to 14 days or more. But once we have the memory cell, it would react as fast as an innate arm. So that is active immunity. Similarly, if we go to the branch above here, what would happen is that in the absence of interleukin 12 and the interferon gamma, for example, or the other important cytokines, and in the presence of interleukin 4, what happens is that the naive T cell becomes T helper 2 cell. And then T helper 2 cell releases interleukin 4, 5, 6, and 10, which causes a B cell to become transformed into a plasma cell. And the plasma cell is the one that is now going to release the antibodies. These antibodies are going to combat the virus. However, the cell, the B cell, would also be transformed into a memory cell, and this would also then go and sit dormant for the next time when the infection occurs. The memory B cell is going to become active and wake up and start making antibodies immediately. So this whole phenomena is called active immunity, because now we can make antibodies whenever we need by our own cells. On the other hand, so of course this takes time, and there are possibilities when you cannot wait for the immune system for 7 to 14 days to become active. You are afraid that the virus is going to cause more damage before the immune system kicks in. For example, in the older age or in the patients with the comorbidities, and you don't want to take a risk. So in that case, these antibodies that our B cell were supposed to make in 14 days, you are going to bring those antibodies from outside and inject them in the person immediately. So remember, our own cells are not making them now. They are actually coming in from outside. So that is what is called a passive immunity. In the case of passive immunity, what we do is we find antibodies by various companies like Regeneron. These antibodies are already present. We infuse them in the patient who is infected, and then those antibodies would provide immediate care for the virus. However, these antibodies are not going to train our immune system to say, hey, when this virus arrives again, let's say 20 days later, then the B cell should behave this way or that way. That is not going to happen. Antibody is just going to do its function, mop up the virus, and then be cleared out. And normally antibodies can stay in the body anywhere from 4 to 6 weeks. Some are engineered in a way that they can stay longer, for example, 2 months, but still that is a limited time for which antibodies can be there, and then these antibodies are going to go away. So this is passive immunity. Back here, if you go back to the active immunity, you could produce active immunity by having the normal infection, that is called natural immunity, or by giving a vaccine, which would also train the immune system in a similar way, which is called vaccine-induced immunity. On the passive immunity side, you can give antibodies from outside, and as long as these are there, they would have an effect. If during that time, our immune system gets a chance to actually be exposed to the virus and then develop our own antibodies by this mechanism, then within 7 to 14 days, we would start having active immunity as well. And the passive immunity would have provided cover while the active immune system is becoming ready. Another example of passive immunity is mother to child. So when a baby is developing, a fetus is developing inside a mother, then mother can actually send antibodies through placenta to the child. And please remember, for that, I've discussed this in the past as well, IgG. And I always say that the G looks like a pregnant belly. So IgG is the antibody that can cross placenta and go from mother to the child and provide immunity. So now this immunity for the child is provided by the mother, and child has not made their own antibodies. So this is also an example of passive immunity. So that is the discussion for today. Thank you very much for joining. I think I'm going to see what happened to YouTube's side of it, but I hope that the folks on Facebook, you enjoyed it, and we would now talk again on Monday. Please, during this time, like, subscribe, and share. Thank you very much, and bye-bye.